Okay, so spasticity is one component of what we call the upper motor neuron syndrome. What we mean by upper motor neuron syndrome is a syndrome associated with central nervous system injury, so the brain or the spinal cord. And the syndrome is really what we call a constellation of symptoms, one of which, as you might guess, is spasticity. There's both positive symptoms, this is what we refer to as positive symptoms, and negative symptoms. And again, this is damage to central nervous system and the pathways that travel to our muscles. And so positive symptoms, spasticity, as you might have guessed. Similarly, that muscle overactivity, clonus, an abnormal reflex that we'll see. Intermittent spasm. So this is slightly different than what we commonly use as the definition of spasticity. Spasticity, we'll get into the definition, but it's always apparent, whereas spasm can be intermittent. Risk reflexes on exam, and dystonia is another type of what we call hypertonia. So I refer to hypertonia as an umbrella term, which in its basic definition just means increased muscle tone. And there's different subtypes of increased muscle tone, spasticity being the one that we'll focus on today. But other types of increased muscle tone you might see in certain conditions, such as Parkinson's disease, for example, where you might see rigidity. There are negative symptoms associated with the upper motor neuron syndrome as well. And this can be seen in muscle underactivity or low muscle tone. We can see weakness, decreased dexterity that impacts our ability to perform fine motor movements and ADLs. Paralysis, weakness, easy fatigability is also something that we'll see as a negative component of the upper motor neuron syndrome, in addition to slowness of movement. Okay, so I don't want to get too scientific, but one thing that patients will commonly ask is why are my muscles getting tight? A very basic explanation is that when we have a stroke, we have injury to our brain, some of our reflexes that control our muscles, both in our central nervous system and then peripherally, are injured. And so typically we have what's called an inhibitory reflex. So our brain is telling our muscles to relax at rest if we're just sitting and talking, for example. And in a stroke, that reflex can be damaged. And the message that was telling the muscles to relax is essentially ridden with errors, and our muscles are tonically being activated when they should not be. When we talk about tone, muscle tone, again, I think of it as a spectrum. And so on one end, you have flaccidity. The opposite end, you can have rigidity or even contracture. Contracture is when our muscles have gotten so tight and that spasticity has been so unrelenting over time that we actually lose the ability to range the affected joint. And so we might have an arm that gets stuck at a certain degree. Even with all the force in the world, you can't progress beyond that. At that point, it's more of an orthopedic or joint issue. Our goal in treating spasticity is prevent the joint ever getting to that point. And so we'll focus on how we do that, how we prevent the spasticity from interfering with our life and progressing to some more problems. So the textbook definition of spasticity is a velocity-dependent resistance to the stretch reflex or the passive muscle movement. So if I'm evaluating you in clinic, it might be kind of uncomfortable because I'm really going to be cranking on your limbs to try and evaluate just how much resistance I'm getting to that movement, okay? In actuality, you'll see the spasticity, it's not just velocity dependent. So even if we're moving your limb slowly or you're moving your limb slowly, you'll see that increased muscle tone. But this is the textbook definition and gives us just a good objective way to evaluate. And so again, this is hyperexcitability of the the stretch reflex. So it's a difficult concept, but you all, or many of you, are intimately familiar with how it actually affects you. So how common is spasticity after stroke? Well, we don't exactly know. We know it's a wide range, anywhere from 17 to approximately 50% of folks who've had a stroke will develop spasticity. So more than half will describe it as muscle tightness that makes arm or leg movement difficult. We see an increased incidence in patients who've had strokes in the brainstem, hemorrhagic strokes as opposed to ischemic strokes, and patients who have strokes at younger age are more prone to develop spasticity, but it can be present in all ages. The more severe our neurologic deficits are after a stroke, so the more significant the weakness or numbness, we're likely to see an increased correlation with spasticity as well. Physical consequences, we've mentioned this briefly, but obviously this is going to restrict our normal movement. And so this is certainly going to have the potential to interfere with our day-to-day activities. It might alter our gait patterns. It might make it painful for us to move our extremities as well. Ultimately, if the spasticity goes untreated, it can cause tissue damage and even have effects on the joint over time. So when does it occur? Well, there's a wide range. Typically we do see it within the first 3 months. There's some folks where I'll see it develop in actually the first few days after stroke. Again, there seems to be a correlation with the severity of stroke and the timing of that increase, or I should say, presentation of spasticity. For the most part, we'll at least see the initial symptoms and present themselves when folks are on our rehab unit. That's typically within the first 1 to 2 months after stroke. Talked a little bit about how we assess it. So it's going to be that velocity dependent type of muscle stretch. We're really trying to range your joints quickly. And then there's different scales that we use. Some are clinical based and some that are research based. And so some are actually what we call electrophysiologically based, where we use what's called an EMG to listen to the activity of the muscle. Typically, I'm using what's called an Ashworth scale, just to make it simple for me and to have a scale that we can use over time as we're treating patients with spasticity in clinic. And it's really just a 0 to 4 scale. 0 is no muscle tone or no spasticity whatsoever. And 4, on the opposite end of the spectrum, is a joint contracture, unable to move the joint. Where most folks are living is in between, the 1 to 3 range. Some of our physical therapists, occupational therapists, as patients are undergoing ongoing therapies, will do repetitive task training, and certain scales will be associated with that type of training. Fugl-Meyer 9-hole peg test, maybe you've done some of these activities, but these are other objective ways that we can measure how the spasticity is affecting you. And then ultimately, it's really about quality of life and getting the spasticity controlled to the extent that you're still able to do the things you want to do. Travel, take care of your family, or be with your grandkids, or get out in the community, whatever it is that you like to do. Ultimately, that's the end goal here. This again is the Ashworth scale, the 0 to 4 scale that we use. More so for us as clinicians, but this is something that we'll at least have in your chart or as part of your assessment, so we know how we're doing with our management. So when should we treat it? Again, if your function is impaired. For patients that are lower level and might be wheelchair dependent for mobility, if we want to improve positioning in our seating, we can treat spasticity. So really, patients along the entire spectrum, whatever level you're at, we'll meet you there if your goal is to get your spasticity better improved. Again, on the lower functioning level or side of the spectrum, for folks who are reliant on caregiver support, treating spasticity can make it easier for caregivers to help their loved ones get dressed or take a shower or bath or transfer. So it's really a comprehensive goal that we have for patients and their families. And obviously we want patients to be comfortable. And this is just some additional treatment goals. See, many of you today have orthotics that you use for mobility. So we want you to get an optimal fit, whether we're talking about an AFO or an upper extremity orthosis or a wheelchair. Cosmesis is the term used here, which when we think of one treatment option, Botox, we're not talking about giving you injections to make your wrinkles go away, but really to give you more of a natural gait pattern. So a lot of patients will have what we call a hemiparetic gait pattern, where the arm is flexed, leg is extended. And so if we can address the spasticity, we can hopefully get you walking a little bit more naturally. Okay, we've talked about, forgive me, a lot of these slides are somewhat repetitive. At least it's getting the message across, right? Increased range of motion, increased spasm. I think this is a duplicate slide. Okay, so we'll start with some treatment options. And I was happy to see you all stretching here today, because that is, by and large, number one. It's the right answer in real life. Hi there. It's the right answer in the textbooks and for our test questions. And it really is kind of the foundation of any spasticity treatment plan. So we'll talk about medications. We'll talk about injections. We'll talk about some other interventional options. But without the stretching, we're really not delivering a comprehensive plan to you. And so that's where your hard work comes in, hard work of the therapists that we work with. And so I'll continue to reiterate this, but was happy to see you all working on your stretching before the presentation today. As far as additional things that we'll do, and I'm going to talk from more conservative treatment options to more invasive as we go here. So splints or orthoses to try and provide optimal positioning, pressure relief, and prevention of possible contractures. A lot of this we do in the acute phase for patients who are having, the acute treatment of their stroke and they're in bed for a prolonged period of time, which we do not like as rehab docs or therapists, but we want to make sure that we're not developing any pressure injuries. As patients progress, we want more dynamic types of orthoses that will be adaptable and moldable as our patient's range of motion improves. And so I don't have in this presentation many pictures of different types of splints, but the ones that we commonly like are dynamic Sabo stretch. I'm not affiliated, by the way, with any company here, but that's one that we commonly use. And it's a softer neoprene with kind of a rigid undergirding that you can mold. As your tone improves, you can change the angle of the splint to reflect that. Serial casting, not commonly used, but it's an option. It's very intensive. Patients will come in. They'll actually have casts supplied, hard casts like you'd see in a fracture in an orthopedic clinic. And the angle of the joint is set at different angles over time. So this is a little bit more cumbersome, not something I'm typically recommending for folks. Electrical stimulation is something that you'll do often in conjunction with your therapist. For example, for patients who have foot drop after a stroke, there's certain devices that you can use to apply stimulation to what we call the fibular nerve to try and activate the muscles and combat that spasticity and posturing. Cold heat application, these are good for spasticity, again, readily available. And then obviously the activities that you're doing here, stretching, walking, exercise. Okay. This again goes back to when we're treating. I think I've talked a lot about this. The only point I'll emphasize here is that it's a heck of a lot easier to treat the spasticity when we're involved early. I've had folks come to my clinic maybe years after a stroke They've only been seen maybe by their primary care physician in a rural area. They don't have as much expertise with spasticity management. Sometimes it's a little bit too late, to be honest, as far as making really dramatic changes or improvements. So the sooner we can see you, the sooner we can treat, the better results we get. But it's never too late. I don't mean to discourage you. It's never too late to be evaluated, particularly if the spasticity is interfering with your quality of life. We want to make sure we match the patient to the appropriate treatment plan. So if patients are going to have difficulty taking a medication 4 times a day, if remembering to take your medication once a day is troublesome enough, then maybe not the right treatment option would not be the right treatment option to have a medication you need to take on the dot every 4 hours, right? And so that's when we might think about other types of treatment options. Sure. Yeah.
Now, I'm saying that you come from wrong to the end at question. Okay. What you just said, you might wait too long and for the take pronounce word.
So
back at one step. The base.
going back.
That, but for the most part, you said you can wait too late for to catch, right?
So essentially, what I was trying to convey was the sooner we evaluate you for spasticity, the better outcomes we're going to have. If the spasticity goes untreated for a prolonged period of time, then it makes it kind of hard to catch up. You get the effects that we want with regard to our treatment.
Okay, now, since you're on that topic, now first, with that no stroke, and I started off on all like now, I'm on horizon, yellow.
Yeah, you're on a couple of medications, Baclofen, and okay.
So, but I'm bad, but really cool. I mean, we together or in between.
Yeah, so I guess the question you're asking is there a cure, right?
Well, I mean, it was another medication. I think that's top of mind, and I talked to the pharmacist.
Okay, yeah, and I'll talk about some of the medications because there are multiple medications, and for some reason, for whatever reason, some patients respond better to others. And then dosing is also a consideration. And sometimes we combine medications to get the right effect. So yeah, there's lots of treatment options that could improve your symptom control.
I definitely have a list of when you say combine.
Yeah. Yeah. We'll get there, but yeah, that's definitely part of the topic. So we talk about spasticity management. I mentioned that stretching is kind of the foundation. This here is just kind of a concept map of all the different types of treatments that we're going to provide to patients or can provide to patients. So this includes rehab, obviously, oral medications, injections, potentially orthopedic interventions, or even surgery if it gets to that point. Nociception, that's essentially pain control that we're trying to achieve. And ITB therapy is intrathecal Baclofen. Baclofen is the first line drug that we use, and we'll get into some of the medications. But again, stretching. I have this slide I think a million times here. We talked a lot about the non-invasive treatment. So let's talk about some of the medications that we use. So Baclofen is the first line agent that I typically use. It's been studied and used for spasticity for years. It works centrally, so it works in the brain as well as the spinal cord. So there's a specific receptor, a downregulator of our central nervous system that works through a neurotransmitter called GABA. Baclofen works as a GABA analog at what we call a GABA B receptor, okay? I'll just briefly run through these and then talk about some of the pros and cons. Diazepam is in a class of medication called benzodiazepine. So these are medications like diazepam or Valium, or you might be familiar with Klonopin or clonazepam, alprazolam, or Xanax. It's a very short-acting drug. These are more typically indicated for really severe spasticity. I'm typically using this for patients who've had spinal cord injuries that have really not gotten benefit from other medications. Dantrolene is unique in that it's one of the medications that works peripherally, so actually at the level of the muscle. Unfortunately, I'll tell you, in clinical practice, we don't tend to see as good of a response as we do to some of the other drugs with regard to the tightness. And Tizanidine, this is probably the second most commonly used medication, and I'll use this as an adjunct or additional medication to patients that are already on Baclofen. This works centrally as well. Alpha-2 receptors, this can have an effect on blood pressure, but it's usually pretty mild. For these medications, it's always important that we take a full history. We need to know how your kidneys are functioning, how your liver is functioning, because that can impact how you're metabolizing the drugs. What I'll say about these drugs, with the exception of dantrolene, they're all working centrally. They can all make us a little bit sedated and fatigued. With stroke, one of the most common symptoms we see is fatigue and sedation. So it's a little bit of a head-on collision there as far as what we're trying to get as far as relief of our symptoms, but particularly in the acute phase of our stroke, a lot of patients are sleepy. We want to make sure we're not contributing to that because it's hard to be functional when we're falling asleep. Dantrolene, again, acts peripherally, so it's going to bypass any kind of sedating mechanisms. Unfortunately, like I said, not typically as effective. So a combination of drugs can be beneficial for patients. What we'll do, we'll start a drug. Sometimes patients will notice feeling really sleepy right when we start it, and we start at a low dose. We always start low, and then we can go up more slowly. And hopefully improve patients' tolerance. So our body acclimates to these drugs pretty well over time. Okay. One other consideration with these drugs is that what we call the half-life. So that's the amount of time at which half of the drug is still available in your body. It's relatively short. So this can be a good or a bad thing, but the dosing is often multiple times per day. So Baclofen, for example, will typically start folks at twice-a-day dosing, but the maximal dosing is taking the drug every 4 hours so that there's always available drug in our system to counteract the spasticity. And so this is working. Yes, sure. Yeah, exactly. We'll get to the pump here after the oral medications, but a very good point. So the oral Baclofen has to go through what's called the brain-blood barrier. And so that's to get the drug metabolized to where it's going to be active and actually working for us. It's going through that brain-blood barrier that's going to cause a lot of the sedation, but also cause a lot of the drug to essentially be wasted. It's not going where it needs to be as it's being metabolized. So poor penetration is a good term for it because that medication is just, you have to get to pretty high doses of the oral pill to get a good effective dose in the brain. And we talked about these side effects. So maximum dosage, typically 80 milligrams. Some folks will have up to 120 milligrams. And we'll get to the intrathecal Baclofen pump because that's a good way to bypass having to go through the brain-blood barrier, where we're losing some of the effectiveness of the medication. This is a little bit more pharmacologic detail, but the benzodiazepines we'll talk about briefly. So I talked about how Baclofen is a GABA receptor analog. That's a down-regulating receptor in our central nervous system. There's two subtypes. Baclofen works at B, benzodiazepines work at the A receptor. I don't want to get too much into the pharmacology, but we're going to see a lot of the same side effects that we see from the Baclofen. We're going to see a lot of sleepiness. We're going to see difficulty with concentration, difficulty with coordination. And typically in our elder population, we like to avoid these sedating medications as much as we can. Because when you get the pill bottle and it says, please do not operate heavy machinery when you're taking this drug, these are the kind of things that we're talking about. But even more so than heavy machinery, it's be careful when you're getting up in the middle of the night to go pee, because you could fall. We don't want you to have those issues, okay? It can be somewhat habit forming. You can become excessively reliant on this drug too, and that makes it difficult to manage this medication for patients. Tizanidine, I really like Tizanidine in addition to the Baclofen. It seems to be more helpful for the intermittent spasms that a lot of patients are having. So it's a subtle distinction between the spasticity, which is always present when we're ranging your muscles. Some folks, really, when you range those muscles, they're not excessively tight, but they'll complain of intermittent muscles grabbing and spasming and seizing, and Tizanidine can be very effective for that. And I won't get too much into the pharmacology here, but again, these medications are short-acting. Tizanidine side effects, in addition to the drowsiness and sedation, can have some dry mouth. Dantrolene works at the level of the muscle, essentially releases calcium from what's called the sarcoplasmic reticulum. Doesn't work on other types of muscle in the body. So we have skeletal muscle, right? We have cardiac muscle, we have smooth muscle. This just works for skeletal muscle. Results, unfortunately, are pretty modest. It'd be great if this worked better than it does, because it really does bypass a lot of those side effects. That being said, there's side effects with every medication. Some folks will get dizzy with this one. That's the most common one that I see. Okay, we'll progress to the next treatment option, and one that I probably use most commonly. The drugs, as much as I talked about how helpful they are, I probably talk as much, if not more, about the harmful or negative consequences of these drugs. You have to take them frequently. They make you tired. You have to make sure your kidneys, liver function is doing okay. And then the results can be somewhat modest, okay? So interventional treatment options like Botox can be really helpful for folks, particularly for patients who have muscle tightness in a very well-defined or focal area. So these are patients that are coming in and have tightness, hand, wrist, elbow flexor. That's a really good candidate. Or if we're seeing patients that are having tightness in their quads or their hamstrings, or what we call our ankle plantar flexors, or gastrocs and soleus back here. So patients that have a more localized pattern of spasticity are a good treatment, are a good candidate for this type of treatment. So Botox, and I'm sorry to use the slide from the company itself. Botox is just a name brand of one strain of botulinum toxin. So just like there's different brands of soda, Coke, Pepsi, Sprite, etc., RC Cola, whatever, if they still make that anymore. Botox is just one product made by Allergan as a pharmaceutical company. But it's important to know there's different strains, and I use different strains in clinical practice. There's one called Xeomin, there's one called Dysport, another called Myoblock. They work similarly, but just we commonly use the term Botox to refer to all of them, but I just want to point out that distinction. And so Botox is a neurotoxin, and It's derived from a living source, but essentially, if you've heard of botulism, that's if you're ingesting spores of botulinum toxin to a potentially lethal dose. But what they notice is that it essentially weakens the muscle, and if you're overdosed on this naturally occurring toxin, you can have paralysis and even death. So I don't mean to scare you, but physicians and physician scientists have been able to utilize this toxin in small doses for a variety of treatments, one of which is spasticity. And so what it does, I won't get too far into the weeds here as far as the mechanism, but essentially we have our nerve, and that's where electrical messages are being sent from the brain along our corticospinal tract. So message is getting to the end of the nerve. On the other side, so there's the end of the nerve, and then here's the muscle. In between, there's what we call the neuromuscular junction. Typically, the nerve will release a neurotransmitter that's called acetylcholine to in turn signal to the muscle to activate the muscle. What Botox does is it blocks the ability of the nerve to release that messenger to the muscle, which in turn prevents that abnormal contracture of the muscle. So it's a toxin, but it's using the appropriate doses to give us relief from the muscle tightness. We're not paralyzing the muscle, but we are in essence making the muscle somewhat weaker, and that's to be expected because that's going to give us better range of motion. And if we do have underlying fine motor control, then it can unmask some ability potentially to better utilize our affected limb. Okay. This is more for my residents when I'm talking about it. Back to Botox. Typical length of action is about 3 months. So folks who are getting benefit from the Botox will typically come in for repeat injections every 3 months, which I know is not everyone's favorite thing to do. See some of my patients here who I know, it's not their favorite day of the season, I'll say that. It's when they come in for injections, but it can be really helpful. What I'll also say about it is that it's both an art and a science. And what I mean about that, talk about the science here, where the art comes in is identifying the appropriate muscles, identifying the appropriate dosage per muscle. And then also what we do is we take the toxin, which is actually, if I were to hand you a vial of botulinum toxin right now, you'd look at it, you say, there's nothing in here. You know, what am I paying you for? It's a really fine powder that we then dilute in normal saline. And so we can come up with different, I should say we formulate different dilutions so that we get different spread throughout the muscle. So that's where the art comes in as far as trying to get the best responses, okay? Any questions about Botox before I keep going, or you can save it to the end as well? Okay, so for patients who have kind of struck out when it comes to the medications, the Botox either not giving us the intended benefit that we hope for, or we just don't want the injections, whatever the case may be. There's one more option that I'll typically manage before referring to surgeons if we have a joint issue. And this is an intrathecal Baclofen pump. So we talked about that Baclofen having to get through our system, penetrate the brain-blood barrier, and by the time all is said and done, only a very small portion of that drug that we're taking is actually taking effect where we want it to take effect. And so let me see if I can get a picture for you. Okay. So essentially a Baclofen pump is, see, do I have a light here? So it's a small metal reservoir, okay? It kind of looks like a pacemaker if any of you have seen that. It's typically implanted just underneath the soft tissue of the stomach. It has a catheter, so a small tube, okay, that's then introduced into the area surrounding our spine that contains our cerebral spinal fluid. The pump typically will program to continuously administer that medication directly into the cerebral spinal fluid. It bypasses having to go through that brain-blood barrier, and this can give us an increased effectiveness. So if you have an equivalent dose, one dose with the pill, one dose via the pump, the medication via the pump can be anywhere from several hundred, so I've seen to as much as 1,000 times more effective, okay? Obviously, the doses we use are much, much, much lower when we're talking about the intrathecal pump. Typically, what I'll say about the pump is that it's most effective for what we call diplegic hemiparesis. So basically, gravity doing its thing and taking its course, the medication is going to be more effective for tightness in the legs as opposed to the arms. Yes, ma'am.
Not this, but I get friends who has some spastic cerebral palsy. He has exactly, we talked about eyes, something like that.
Yeah.
It's not really.
Yeah, it can be a really life-changing type of intervention for folks. And so I will say, as I mentioned, the pattern is typically patients who have both legs affected. And for that reason, it's not typically one of the first things that we use for stroke patients, and you might not be a candidate for it, because a lot of folks with a stroke are having tightness on one side of their body. So if we're making both sides of the body loose, that can have harmful effects. But what I will say is that before we'd ever jump to putting a pump in you, it's a big surgery. Again, if we've kind of struck out with regard to the other treatments, we would do a trial. And so I have colleagues in anesthesia that would essentially just inject a small dose into that area where the pump would lead to. Physical therapists, occupational therapists would do a test of your muscle joints, of your muscle range of motion before the trial, give you the injection, and then you get another test afterwards. And if we see some pretty good improvement, then we call it a successful trial and you might be a candidate for it. But typically, it's for more severe spasticity, but it can be a life-changing type of procedure for folks. This is just some of the detail regarding the pump and the programmer itself. For folks who end up getting the pump, it can be a little bit, it's a big commitment, not a little bit, it's a big commitment. You have to be very adherent to coming in for your refills. If you don't get the medication refilled and you were to run out, you could have some very serious side effects. And I'll just mention it because I didn't mention it earlier. Same can hold true to a lesser extent with the oral Baclofen. So it goes for all medications, but particularly with Baclofen, anytime you're thinking about wanting to get off the Baclofen, let your doctor know, because you have to do so gradually to avoid any serious side effects, okay? So typically with the pump, it's a surgery, and you're gonna have frequent visits in the month or two after the surgery to try and get you to the right dose. So again, this is a little bit of where the art comes in, trying to get you loose, but not too loose, because we don't want you to have any buckling or falling or decreased dexterity or weakness that's harmful to you. Okay, and then just a couple of illustrations of how I might treat some of these types of presentations. So this is a patient predominantly, as you can see, finger flexor tightness. So this is a patient that would be really good. If they don't have tightness really anywhere else, this would be a really good Botox candidate. We would just inject the finger flexors themselves and hopefully have a good result without any of the side effects of the oral medications. So I'll kind of move through here. This is something that I'll have patients complain of. So we kind of see two things here. We see obviously the big toe and extension. We call that striatal toe, but I do have more commonly patients that have toe flexion spasticity. And that makes it really uncomfortable as they're walking because their toes are constantly being flexed at those joints. So again, this is another patient who would benefit from Botox.
Well, quick question.
Sure.
Instead of step the toe point up, is it the same like? With that, with ground?
So I'm sorry.
Okay, spasm. I mean, instead of, going up, it like hitting the ground.
Yeah, so more commonly, we'll see that pattern where the toes are actually flexing.
Right, and then you have to match muscles so straighten that out. Fine.
Yeah, so that's what we're trying to achieve with the treatment and stretching is relaxing those muscles, which actually are predominantly in the leg. So the muscles in the leg, they have the tendons that are inserting on those joints that are then causing that contraction. Other things we can do is we can do some orthotic prescriptions for you to try and get you footwear that's a little bit more comfortable for you. And also taping. So if it's mild, then we can utilize taping to try and achieve a more natural type of positioning of your toes. So there's different things we can do for that. But yes, the toe flexion is actually more commonly what we see. Did that answer your question?
Yeah.
Okay, great. And so this is a patient, this is more significant spasticity that we're seeing. So we're seeing actual wrist extension. We see tightness. I'm guessing we actually probably have tightness both in our arm flexors and extensors as well. We have finger flexors, we have extension in the quadriceps, we have significant plantar flexion and inversion. So this is a patient with pretty severe hemiparetic one-sided spasticity. So this is a patient, yeah, we could try, obviously, oral medications. We can try Botox, but we're getting to the point, we're really talking about a lot of muscles here that we'd be injecting. And we're limited too by how much Botox we can use. Our system can only handle a finite dose before we start getting adverse effects. So when we start taking Botox and splitting it up amongst 10, 15 muscles, we might not get the results that we want. And so this might be a patient that could potentially be a candidate for a pump trial. This is that common hemiparetic posture that we'll see after stroke. So typically what we'll see in the upper extremity, everything is kind of flexed in, our arm is internally rotated and adducted. We're flexed at the elbow, our wrist is flexed, our fingers are flexed. And so this is one of the most common postures that I'll treat in clinic. And again, this treatment regimen's going to be very similar. It's going to be that progression. Always, what's the first thing we're doing for patients? Most important thing with our treatment plan? Stretching, there we go, okay. Positioning, orthoses, then we're talking about medications, potential injections. This goes into a little bit more detail about oral Baclofen and its ineffectiveness as compared to the intrathecal Baclofen. Again, stretching. Okay, I think I've left you about 10 minutes for questions before lunch. So any additional questions I can help answer? Yes, ma'am.
When you count bad moths